and joining us in this live webcast entitled Heart Failure Global Conclave Webcast. For your information, this session is being recorded. Although all attendees are muted throughout the webinar, we encourage your participation in this webinar by submitting your questions, if any. We will compile these questions for discussion during our Q&A session later and try our very best to address them. If I may have your attention to the presentation slide now, please allow me to quickly guide you on how to raise questions. For those of you who are joining this webinar via personal computers, you will see a similar screen as shown. On the top right of your screen, the first button, which resembles a microphone, will stay muted throughout the webinar, whereas the button right below it is the virtual raise hand function, which you may use if you have difficulty in hearing or seeing the webinar. Next, we have the questions button, which you may use to send in your questions. For those of you who are joining this webinar via mobile devices, be it mobile phones or tablets, you will see a similar screen as shown. On the top right of your screen, the first button, which resembles a hand, is the virtual raise hand function, which you may use if you have difficulty in hearing or seeing the webinar, whereas the button next to it is the microphone, which will stay muted throughout the webinar. Next, we have the questions button, which you may use to send in your questions. I shall now pass the virtual stage on to Dr. Shantia of Novartis.
Hi, Dr. Shantia, you are muted.
Thank you. Good evening, ladies and gentlemen. I'm Dr. Shantia from Novartis Malaysia's Heart Failure Medical Team. We would like to extend our warm welcome and thank you for participating in our webcast today, which is part of our Heart Failure Global Conclave initiatives. For those who are here from outside of Malaysia, good day to you and thank you for your participation and support. We are pleased to have with us today Prof. Roy Gardner, who will be discussing on how to treat heart failure patients with reduced and mid-range ejection fraction. Allow me to introduce our esteemed chairperson for today. Dr. Hamad Hamdi Che Hassan is the head of Cardiology Unit in Pusat Perubatan University Kebangsaan Malaysia, otherwise also known as the National University of Malaysia Medical Center, where he has been with the institution since 2009. Upon receiving his medical degree from the University College of Dublin in 2001, he had obtained his MRCP and continued to practice in cardiology. He had completed his invasive cardiology training in the year of 2006. Dr. Hamad has published many articles till to date in both local and international peer-reviewed journals. In addition, currently he is also involved in many international clinical trials, including in the field of heart failure. Dr. Hamad is active in continuing the medical education for Malaysian medical professionals by his involvement in teaching, research, along with his invasive cardiology service. Without further ado, let's get started with today's webcast. Thank you, and over to you, Dr. Hamad.
Thank you very much, Dr. Shantia. And first of all, thank you, Novartis Malaysia, for staging this webinar, which will be helpful to all of us in managing our daily medical practice. And today we will have our distinguished speaker from UK, Scotland, which is Professor Dr. Roy Gardner. He is an honorary professor of medicine at the University of Glasgow, and he is the lead of cardiologist in the Scottish National Advanced Heart Failure Service, as well as the physician at the Golden Jubilee National Hospital. He is also the chairman-elect for the British Society of Heart Failure and also International Editorial Advisory Board for member of the Biomarker Journal in Medicine, which is the Future Medicine. In addition to being a member of the ESC, European Society of Cardiology, and also the Royal College of Physicians of London, he also the author and editor of the Oxford Textbook of the Heart Failure and the Oxford Specialist Handbook of the Heart Failure. Professor Gardner's research interest is focused on the advanced heart failure treatment and also cardiac transplantation. So without further ado, I would like to welcome Professor Roy Gardner to give his speech, and I give this virtual stage to him now. Please welcome Professor Gardner.
Sorry, Professor Roy, we cannot hear you.
Can you hear me?
Yes, we can hear you now,
Prof.
Okay, let's start again then. So good afternoon all. It's a real pleasure to come to you this afternoon to discuss the very important topic that is heart failure. We've really come a long way in a short period of time in the management of patients with heart failure, and I think it's fair to say we've still got quite a bit to do. These are my disclosures. Now, when I discuss heart failure, I often show this slide. It's a somewhat distressing image. It's an image that, in fact, was an advert of the largest cardiovascular charity in the United Kingdom, the British Heart Foundation, from 2002. Now, as you would imagine from such an appalling image, this advert was promptly withdrawn because of a number of complaints. But what it did do was highlight the high morbidity and mortality rates patients have with heart failure. But also what it did do was prompt the largest number of phone calls to the British Heart Foundation for help and advice, not just from patients, but also their carers. Now, this trajectory is often shown, the almost inevitable decline in heart function and quality of life experienced by patients with heart failure, interspersed with these periods of decompensation. But of course, at any point in the trajectory, patients can experience sudden death. But I think we're all aware now that the trajectory isn't always like this. I've got a number of people that we assessed for cardiac transplantation 17 or 18 years ago who are still coming back to clinic with a reasonable quality of life. And in fact, many patients who have presented with very poor cardiac function who subsequently have improved, sometimes to normal degrees of cardiac function. Now, the priorities we have when managing a heart failure patients is to make people feel better, to keep them out of hospital because that's invariably the most expensive aspect of heart failure care, but also to prevent patients dying prematurely. Now, many of you are too young to remember this. I certainly am. This was from 1964 from a Glasgow teaching hospital, and this was before the general availability of loop diuretics in 1966, one of the ways that they managed peripheral edema using Southeast tubes to drain edema into cups. So not that long ago, this is how we're managing heart failure. And in fact, heart failure therapy in 1985 was very similar to 1785 when William Withering found the medicinal uses of the foxglove plant, and from which we obtained digitalis. Now, I'm very fortunate in that I work in Glasgow, and really from a very early stage, it was apparent that heart failure care was very, very integral to the way that cardiology care worked within the west of Scotland. And really because of some key individuals who I had the pleasure of working with. Now, you will be aware of many of these individuals. In the top right-hand panel, we have John McMurray, who has been somewhat instrumental to a number of heart failure studies, including Paragon HF and CHARM, and so on and so forth. The bottom right-hand panel, we have John Clellan, who's the principal investigator for CARE-HF with CRT pacemakers. Henry Dargy in the middle there, principal investigator of CIBIS-2. Up in the top, in the smaller bubble, we've got Ian Ford, who is the statistician involved in many cardiovascular studies, particularly heart failure studies. And of course, in the black and white image in the bottom, we have Sir James Black, the inventor of the beta blocker. So as I say, heart failure was something that was drummed into me from a very early stage in my career. And really over the last 33 years, we've had a wealth of data presented to us on how we manage patients with heart failure. And really this started in 1987 with a consensus study where enalapril was compared with placebo. And from then on, we had the development of the renin-angiotensin-aldosterone system and sympathetic nervous system, and our knowledge and understanding of those systems and how interfering with those systems could alter a patient's outlook. And really, things have moved on to emphasis and Paragon and DAP-HF, and we'll mention some of those in today's presentation. So up until recently, we had ACE inhibitors, beta blockers, and MRAs as the cornerstone therapies in the management of heart failure with reduced ejection fraction. Now, although this pyramid looks very broad with device therapy and some very advanced options such as transplant and mechanical circulatory support, in fact, the pyramid is much narrower in this. These are very niche therapies for a small proportion of individuals where these things are appropriate for. But the masses should be obtaining these cornerstone therapies, and that's where we were until recently. Now you'll be aware that sacubitril/valsartan is a marriage of an angiotensin receptor blocker and a neprilysin inhibitor, and together these drugs are vasodilators, natriuretics, and antifibrotics. So very important aspects we think we can interfere with in the hope that it will improve patient outcome. And of course, the Paragon HF study, which was presented and published in 2014, you'll all be very aware of this, was strongly positive. Now, this is a very important study for a number of reasons. Firstly, this was the first time we took a cornerstone drug, the ACE inhibitor enalapril, and compared it with the challenger sacubitril/valsartan. Up until then, all of the drugs that we were really gaining information about were placebo-controlled trials, but this wasn't placebo-controlled. This was an active comparator, and a very good one at that. And something that we also often forget is the fact that this study was stopped prematurely by the Data and Safety Monitoring Board because of overwhelming benefit after a median follow-up of only 27 months. And you can see on the Kaplan-Meier curve on the right-hand panel, that very early on these curves diverge. And it is very rare that you see a p-value so highly significant as the one that you see here. And in 8,500 patients, there was a 20% relative risk reduction in cardiovascular death or hospitalization for heart failure. And that's a number needed to treat of 21. Now, in combined primary endpoints, which are very common these days, often it has been driven by one of the components of the primary endpoint, but not so in Paragon HF, in that cardiovascular mortality was reduced by 20%, and heart failure hospitalization was reduced by a very similar degree, again, both statistically significant. We see, for example, from the HFrEF study with ivabradine, the primary combined endpoint was being driven by heart failure hospitalization, but here, both cardiovascular death and heart failure hospitalization. And what I think is really quite compelling is that you can see that sacubitril/valsartan reduces heart failure hospitalization within 30 days of switching from an ACE inhibitor. So the longer we wait to switch a patient onto sacubitril/valsartan, the greater the risk there is to that patient. And that was a 40% relative risk reduction. But not only does it reduce first heart failure hospitalization, it reduces the revolving door of heart failure hospitalizations that our patients often experience. Is it all too good to be true? Well, it's always important to look at an adverse event profile when you're considering a new or a relatively new drug. And in fact, what was very interesting is that less patients stopped sacubitril/valsartan in Paragon HF than they did enalapril. So that was statistically significant. The adverse event that was more common was symptomatic hypotension, but as I mentioned, sacubitril/valsartan is a natriuretic and a vasodilator, and that is to be very expected. And it became quickly apparent, in fact, that when we started using sacubitril/valsartan, and for me it was nearly 5 years ago now, we recognized that the diuretic dose that the patient required very often reduced, and so it became a matter of fact that we reduced the furosemide dose when we switched them from an ACE inhibitor to sacubitril valsartan, and from then we've not had an issue with hypotension. And in Paragon HF, you were less likely to experience worsening renal function or hyperkalemia. So it seems to be a very well-tolerated drug with very beneficial effects. So in fact, where are we with heart failure reduced ejection fraction now? Well, in fact, ACE inhibitors have largely been replaced with sacubitril valsartan, and beta blockers and MRA are vitally important in addition. And then we can think of the fancier things that we can offer patients after we establish the masses on the Cornerstone Therapies for heart failure. And as such, there was a clinical practice update from the Heart Failure Association of the ESC in 2019, which again confirms that sacubitril valsartan is recommended as a replacement for ACE inhibitors and ARBs, and that's important to reduce these important endpoints that I've mentioned to you. But in fact, the HFA went on to say that sacubitril valsartan may be considered in hospitalized patients with new onset heart failure, and in particular those who are naive to ACE inhibitor therapy. And that was largely based on the PIONEER and TRANSITION data that we don't have time to discuss during the presentation, but if there's questions about it, I'll be delighted to do that towards the end. So not only can we consider this as a switch, but also for de novo patients. A very interesting paper that's just been published in The Lancet is looking at important clinical trials of recent times, Paragon HF, DAPA-HF and Emphasis, comparing outcomes with conventional therapy with an ACE inhibitor and beta blocker. Now, obviously, this is just estimating benefit from clinical trials, and the patients we look after don't necessarily represent those clinical trials, but the estimates here were quite compelling. There was a 62% reduction in the primary endpoint of cardiovascular death or first heart failure hospitalization. In fact, the estimation was that if you treated patients with modern therapy, you would afford them between 1.5 and 6 years of additional survival, compared to giving them just an ACE inhibitor and beta blocker. And I think we would all agree that that's a very important message, and I would suggest you read this paper. It's very interesting. Okay, so what about heart failure with mid-range ejection fraction? Now, this is where the quality of data suddenly diminishes somewhat. This is an interesting editorial from Carolyn Lamb and Scott Solomon, where the middle child in heart failure is described as heart failure with mid-range ejection fraction. And this is looking at an EF of between 40 and 50%. And in fact, there's an interesting quote that says the older child, which is HFrEF, gets all the awards, the younger child, HFpEF, gets all the love, and the middle child gets nothing. And I'm saying this as a middle child, in fact, that heart failure with mid-range ejection fraction is something we know far less about. Now, of course, when we look at the spread of ejection fraction, we recognize that, in fact, there are patients out there with an ejection fraction between 40 and 50%, certainly underrepresented in clinical trials. And of course, when we're putting people into clinical trials, often they run as HFrEF studies or HFpEF studies and not HFmrEF studies. So what data are there out there? Well, again, we recognize increasingly that heart failure with mid-range ejection fraction actually resembles a sort of milder version of heart failure with reduced ejection fraction than HFpEF. And in fact, I think you'll find that HFmrEF is going to be recoded as mildly reduced ejection fraction going forward rather than mid-range, because there is this recognition that these individuals act more like HFrEF patients than HFpEF. Now, when we think about the way that we manage HFpEF patients, of course, we're all aware that there's been significant disappointment in using the drugs that we commonly use in HFrEF in such a population in terms of the outcomes that the patients will experience. Candesartan was clearly looked at in the CHARM program with heart failure, CHARM preserved. Now, when we think about HFmrEF, though, roughly about 17% of individuals, that's 1,300 patients, had heart failure with mid-range ejection fraction. With a median follow-up of 2.9 years, there was a reduction in the primary endpoint of cardiovascular death, but not in the HFpEF patients. So in HFrEF, HFmrEF, but not HFpEF. And again, recurrent hospitalizations, seem to be reduced with candesartan. That's Lars Lund's paper from 2018. And when we look at the effect on cardiovascular death or heart failure hospitalization or its components, according to ejection fraction, again, in this blue banded area, there does seem to be some benefit from the use of the ARB candesartan in HFmrEF patients. Similarly, with beta blockers, this is a pooled analysis of 11 beta blocker studies by John Cleland, who is a fellow Glaswegian, and again with ejection fractions of between 40 and 49%, there does seem to be a benefit in terms of all-cause mortality and cardiovascular death with beta blockers in patients with sinus rhythm. Perhaps less compelling is the benefits in terms of hospitalization. And again, there's no suggestion in the HFpEF population that beta blockers serve a patient an advantage. Looked at another way in terms of all-cause mortality or cardiovascular mortality, again, in this HFmrEF population, which you can see in the middle panel of the top and bottom boxes, again, there seems to be a benefit with the use of beta blockers in heart failure with mid-range ejection fraction. The TopCat study you'll all be aware of was a randomized controlled trial of spironolactone versus placebo in heart failure with mid-range and preserved ejection fractions. This was just under 3,500 patients. The patients had ejection fractions of 45% or above and were followed up for 3.3 years. As you can see on the panel on the right, there does seem to be a dependent process depending on your ejection fraction. So patients with a lower ejection fraction, the more HFmrEF patients, did seem to offer some advantage. But again, this is looking at data and subgroup analysis. What we're also recognized from TopCat is there was significant regional variation. So the mortality rates are much higher in patients recruited in the Americas compared to Russia and Georgia. And in fact, spironolactone seemed to have some benefit in the populations from the Americas compared to Russia and Georgia. And to muddy the water somewhat further, there did seem to be a problem in terms of the individuals randomized to the spironolactone group in Russia and Georgia. Around about a third of them did not have metabolites in their urine of spironolactone. And as you're probably aware, they're running a further version of this trial to look at the effects of spironolactone in HFpEF and HFmrEF in a bit more detail. So time will tell if spironolactone is useful for this patient group in addition. We had some early phase 2 randomized control data of sacubitril valsartan versus valsartan in patients with an ejection fraction of 45% or above. These were individuals who had NYHA class 2 to 3 heart failure and an NT-proBNP above 400 picograms per mil. Now, these individuals were followed up for 36 weeks, and the primary endpoint was really looking at a change in NT-proBNP, a very powerful substrate really for cardiovascular poor outcomes. It's something that we use routinely in the UK, as I'm sure you do across the world. And we recognize that a high NT-proBNP is a harbinger of doom. Now, sacubitril valsartan was well tolerated in this population, again with adverse events similar to those of valsartan. And what they saw was a much higher reduction in NT-proBNP in those individuals randomized to sacubitril valsartan, which was previously known by LCZ 696. What they also saw was a reduction in left atrial volume in those randomized to sacubitril valsartan. So some interesting early work suggesting that there might be benefits of sacubitril valsartan in this HFmrEF population. Now, of course, you'll be aware of the Paragon Hf study, which was just under 5,000 patients with NYHA class 2 to 4 heart failure. These individuals had an ejection fraction of 45% or above, evidence of an elevated NT-proBNP and structural changes either with LVH or left atrial enlargement. And they were randomized to receive either valsartan or sacubitril valsartan, aiming for a target dose of 97/103 milligrams twice daily or 200 milligrams twice daily, whichever is the preparation that you have in your country. The primary endpoint was cardiovascular death and total, so that's first and recurrent heart failure hospitalizations. Now, they anticipated 1,721 primary events, which is quite important. Now, again, the Kaplan-Meier curves appear to diverge from a very early stage, but you can see the p-value is rather depressingly 0.06. And unfortunately, it is recognised that under 10 extra endpoints would have seen this being a positive trial. But intention to treat, this was a neutral study, and so therefore further analysis of a neutral study should be taken with a pinch of salt. But what we did recognise is that there seemed to be a signal that sacubitril/valsartan reduced total heart failure hospitalizations, but no suggestion it reduced cardiovascular death. And it's important to point out that sacubitril/valsartan is only indicated currently for patients with heart failure with reduced ejection fraction. But it is interesting to see that there is a suggestion that there's a reduction in heart failure hospitalization. But as I say, this is one of the components of a neutral primary outcome. When we look at the effects of sacubitril/valsartan compared to ejection fraction, as you can see in the top panel here, there did seem to be a difference depending on whether your ejection fraction was above or below the median at 57%, with those with an ejection fraction less than 57% seeming to obtain benefit from sacubitril/valsartan. Looked at another way, so this is looking at the effects of sacubitril/valsartan across the ejection fraction spectrum. Again, work by Scott Solomon. This was pre-specified analysis combining data from Paradigm HF as well as Paragon. And again, you can see that there seems to be a benefit across the ejection fraction spectrum to about 55% in terms of total heart failure hospitalization or cardiovascular death. They're very similar to work that was done previously after Paradigm HF was published by one of my colleagues, Pardeep Jund, where they tried to work out the benefits of sacubitril/valsartan versus putative placebo. And what they did was they looked at the CHARM alternative study and they looked at Paradigm HF and were able to compute a benefit in terms of comparison to placebo. So they've gone one step further and compared Paragon to CHARM Preserve to see if there's any benefit of sacubitril/valsartan, not to valsartan, but to placebo. And again, very similar to Scott Solomon's work, you can see that sacubitril/valsartan appears to benefit patients up to ejection fractions of around about 57% in terms of total heart failure hospitalization and cardiovascular death. Now, this is statistically significant, but remembering that Paragon itself was a neutral study. What we recognize, though, is our heart failure patients aren't necessarily those patients in clinical trials. They tend to be older and they have greater amounts of comorbidity. A very interesting paper from Natalie Conrad from The Lancet in 2018 was looking at heart failure patients from the United Kingdom. And in fact, the number of patients with 3 or more comorbidities with heart failure has increased from 2002 to 2014. Where 87% of individuals with heart failure have 3 or more comorbidities. And their comorbidities are represented here. Now, there's some likely offenders that you'll recognize: atrial fibrillation, diabetes, hypercholesterolemia, obesity, and so on and so forth. But obviously, our patients are more complicated than perhaps clinical trials might suggest. Now, it's important to point out sacubitril/valsartan has been looked at in a pre-specified analysis in HFrEF in terms of common comorbidities like diabetes, AF, and hypertension. And there's no suggestion whether you have this comorbidity or not that you gain any less benefit. In fact, the benefit seems to be across the board. So thinking about potential treatments for comorbidities going forward with heart failure reduced ejection fraction and heart failure with mildly reduced or mid-range ejection fraction, IV iron is something that's been shown to improve 6-minute walk and quality of life in patients with HFrEF. There's a couple of clinical trials ongoing at the moment with IV iron in a chronic heart failure population in Ironman, which is using IV isomaltidase, and also ferric carboxymaltose in the HFrEF study, the latter study being in patients hospitalized with acute heart failure. So we know that iron deficiency is common in heart failure patients, and what we want to tease out is whether IV iron improves outcome in terms of mortality in our heart failure patients. In terms of SGLT2 inhibitors, it's recognized now from the DAPP-HF study that dapagliflozin improves patient outcomes in terms of reduction in mortality as well as hospitalization. And certainly from the DECLARE TIMI 58 study, this seemed to be particularly in patients with HFrEF, but in terms of hospitalization, there was also a signal for patients who didn't have heart failure with reduced ejection fraction. And as such, there are two large clinical trials of SGLT2 inhibitors in heart failure with mid-range and preserved ejection fractions, the HFmrEF, preserved in the DELIVER studies. And hopefully we'll find out more about this class of agent in this patient population going forward. Something that has been shown to be of benefit in patients with both HFrEF and HFpEF is a CardioMEMS device. Now, I'd be interested to hear what your experience with the CardioMEMS device is, but in the CHAMPION study, which was 550 patients from the US, there was a 36% relative risk reduction in heart failure hospitalization. And what they recognized in the PA pressure monitored group is that the PA pressures fell substantially, but actually they rose in the control groups where they weren't gaining access to the pulmonary artery monitoring data. Now, what we saw from CHAMPION is there was nearly a 99% freedom from device-related complications, but because as you probably know, this is a tiny device with nitinol wings, which doesn't have a battery or a computer. It's placed by doing a pulmonary arteriogram, passing a wire down the pulmonary artery, particularly one that's passing posteriorly, so it's closer to the pillow that the patients lie on a daily basis. Over the top of the wire, the device is deployed. It's then calibrated by another right heart catheter, and it's left in situ. And this is what it looks like on chest x-ray. This is an individual with a single chamber ICD, and you can just see on the cardiac silhouette the CardioMEMS device in situ. And what we see are daily trends. Patients lie on the pillow for about 18 seconds every day, and it gives us a pulmonary artery pressure and allows us to adjust the diuretic therapy accordingly. And this is the type of pressure trace that you get, so it can be quite a useful device in reducing heart failure hospitalization in particular. And in fact, we've just hot off the press finished a UK study of CardioMEMS in both HFrEF, HFmrEF and PEF, and demonstrated an 81% reduction in heart failure hospitalization with the use of this device. But of course, it is a very expensive device, and you could certainly pay for very many prescriptions of sacubitril valsartan and other key drugs for the price of one sensor. But it's also recognized this device does work in both heart failure with preserved, and that was described as an ejection fraction of 40% or above, or HFrEF in the CHAMPION study. Something else device-wise that might be useful, this is something that we are involved in clinical trials with, is the Reduce LAP device from DC Devices. And this is where we deliberately make a hole across the atrial septum to reduce pressure within the left atrium. This is an MRI scan with a device in situ, and hopefully you can see shunting of blood from the left atrium at the bottom into the right atrium, offloading this person's left atrial pressure. And you can see there's significant left atrial and right atrial dilatation here. Because what we recognize with patients with heart failure with preserved ejection fraction is whilst the pulmonary artery pressure may be satisfactory at rest, it goes up significantly with exercise, particularly in the left atrium. Left atrial pressure elevates. And with the use of this shunt, you get equalization of pressure. Time will tell if this is a useful device going forward. So what do I think? Well, I think that heart failure care, particularly reduced ejection fraction, has been completely transformed over the last 3 decades. That we don't use angiotensin receptor blockers anymore. They've never been shown to be superior to an ACE inhibitor. And in fact, we know that sacubitril valsartan is significantly superior to an ACE inhibitor. So for that reason, we don't use ARBs now. I think it's only a matter of time before ACE inhibitors are the drugs that are only used in HFrEF, including de novo initiation. I think we'll gain more information from the PARADISE-MI study, which, as you may be aware, is looking at post-MI LV dysfunction. And this study is randomizing patients to sacubitril valsartan or ramipril. And that study is due to report, I believe, in Q3 of next year. We also recognise that heart failure with mid-range ejection fraction acts more like heart failure with reduced ejection fraction than HFpEF, which is good because we appear to have treatments for HFmrEF rather than HFpEF. But I also believe that we should use any opportunity we can to improve our patient care. What will the guidelines say? Well, the ESC heart failure guidelines are due to be updated next year, so time will tell how heart failure with mildly reduced ejection fraction is portrayed. But I think the change in definition is certainly going to be one of them. And so in summary, heart failure patients have a high risk of mortality. We know this. We recognise, however, that we can manage that particularly well with treatments that we have on offer. It's important for us all to remember that even those individuals with mild symptoms, they can have a very poor outlook. And sometimes the first manifestation of worsening may be sudden death. We recognise that succipital valsartan reduces the risk of death and hospitalization in heart failure, reduced ejection fraction, and in fact reduces sudden death by 20% in addition to the data that I've already presented to you. And there is a signal to improved outcome in heart failure mid-range ejection fraction with succipital valsartan. And I suppose I wanted to leave you with this question before you give me your questions is, what would you want to be prescribed if the patient happened to be you? Thank you very much for listening, and it'll be great to get involved in a great discussion on heart failure care.
Thank you very much, Professor Gardner. If it is in the hall, then we can give a big applause, but in the virtual world, maybe give our own applause as well. So, Professor, I think, yeah, that's very nice presentation, and we can see it very clear, the benefit of one of the leading drugs in the heart failure now, which is ARNI. I just love to call it ARNI. It's much easier to remember and very short. So what I see in our local practice here, the one that really we take into granted after the admission to the CCU or CRW or in the general ward is when we did the urgent echo. We try to get echo in the same admission after we treating the heart failure. The only lacking things that we are compared to the research world is the biomarker. So I think in our local practice here, even we are in the teaching hospital, I've been trying to get some budget to use as a routine, the NT-proBNP or proBNP itself for the management, but so far we are still lacking of those additional material, which is the biomarker. We only use that for the teaching purpose, which is the research that we are conducting. It's either our own local research or clinical trial that we are collaborating with all the clinical trial in the world. So that's number one, that we are not able to copy some management that they are recommending in the guideline or in the research itself, randomized control trial research that really give benefit to this type of group. So, and then also we try to get the resource, some extra resource, which is the echocardiogram. It sounds quite easy, but when you are in the general hospital or general teaching hospital, to get the echo done in the next day, I think it takes a good resource for that. So, but when we saw the patient in the ward, after we get the echocardiogram, and when we see the ejection fraction is more than 50%, and some of these patients fall into the mid-range group. So when we see this patient, we try to be relaxed a little bit. I think that's some of the mistake from our physician, from our clinical world here, that when we see this type of patient, that we tend to be relaxed a little bit. Further investigation that we need to be ordered, like urgent angiogram, depend on the ischemic burden or any other type of the investigation. We're trying to slow down a bit. So, and also one of the leading comorbidity in this type of group is the hypertension. So hypertension burden and also the ischemic burden in this type of group, if you calculate the TIMI, sometimes the TIMI score is lower. Then the urgency of to do the angiogram is lesser in this type of group. I think this is the mid-range and the preserved ejection fraction. We tend to be overlooked a little bit in our clinical practice in this part of the world. Any comment from you, Professor, from our first observation for the heart failure admission management here?
Yeah, so some very good points that you've made. So, of course, BNP was discovered in 1988, so it's not a new biomarker, and it's been involved in the guidelines for many, many years now. I have to say, when I took on my consultant role 12 years ago, one of the first business cases I did was to get NT-proBNP, because it is a very valuable biomarker, but it's not, I wouldn't say it's essential, but it's valuable. We have also recognised, it's only very recently in the UK, that BNP has been universally available. And in some instances, particularly in Scotland, we've done that in collaboration with pharma, because as you probably know, NT-proBNP is produced largely by Roche Diagnostics, and many of the pharma companies have, particularly Novartis, have a share within Roche Diagnostics. And sometimes deals can be done where it can lessen the price of BNP. So we pay about £10, which is about $14 for one BNP test. We're not doing it on admission and discharge. We're doing it usually once a week. That's what we would generally do. I check it every time somebody comes to clinic, because I think it's a very useful prognostic marker. As you know, that I manage patients on the sicker end of the spectrum, and what I want to see with the treatments that I'm offering the patient is a reduction in NT-proBNP. That's what you would expect. And in fact, it's those individuals who their NT-proBNP starts to rise despite your best efforts, they're the ones to be very concerned about, whether that's considering them for advanced strategies or indeed palliative care and device deactivation. But it's a crystal ball, it's a form of communication. And I think it's a useful thing to have, but it's not essential. And anything you can do to try and get it would be useful. There are a number of companies working on point-of-care tests as well. There are some available already. We're working with a local company, in fact, who have now developed a point-of-care test that can do 10 different biomarkers from one finger prick test. So that's quite a useful thing as well. And again, it's not that expensive. The kit is roughly about £10 or £15 per shot. So that is something that's useful. I think it's really key to try and get an echo during admission of a heart failure patient, particularly if you don't know what their ejection fraction is, because it helps you mold their therapy going forward. Is that heart failure reduced ejection fraction, or indeed HFpEF that you've mentioned? Now, I have to confess that we are fortunate in the UK in that HFpEF is much less common than HFrEF. Primary care physicians have been incentivized for many years to identify and treat hypertension from an early stage. And so therefore, we don't see much in the way of LVH related to hypertension. And if we see it, it's more likely related to aortic stenosis, or indeed somebody who turns out to have HOCM. So we don't see much in the way of related hypertensive heart disease, but obviously there will be the patients who poorly adhere to therapy. But I think it's key to try and get some imaging of the heart during admission with heart failure if you don't know about the ejection fraction.
Yeah, I agree with you, Professor. And now we are running in our center here the special heart failure clinic once a month. So we have the biomarker in situ and also the echo at the ground as well. So I think that one is really helpful, but that one is really focused on the reduced ejection fraction group that we are channeling to maintain the dose or to increase the dose of the ARNI dose. Okay, so that's the some improvement in our service here in our part teaching hospital here. So yeah, the other thing is I think the ischemic burden, Professor. So in your center, that if you see someone like reduced ejection fraction with some ECG changes, how soon that you are interested to put the patient to the cath lab? Yeah.
So that's a good question. So we don't routinely do angiograms anymore in patients. Increasingly, we're using cardiac MRI, and if somebody has significant late gadolinium enhancement suggestive of coronary disease, we would potentially do an angiogram at that point. What we don't know truly is about revascularization. So there are advocates of bypass surgery in individuals with coronary disease and LV dysfunction following on from stitch and stitches. We're currently running a trial within the UK called the Revived study, which is randomizing patients with coronary disease to PCI versus medical therapy. So hopefully we'll establish whether, if you've got coronary artery disease, is it worth doing something about it? Now, I think it's different if somebody has chest pain. If somebody has ischemic sounding chest pain, then we would do an angiogram, but less and less we're doing it routinely in our heart failure patients.
Yeah, for the special group of the preserved ejection fraction, Professor. So when you're dealing with this type of group, I think some of the questions are there already on the chat box, which is, how aggressive that you want to treat this type of group. As I said, in our center here, what I see from my observation is we tend to overlook this group, which is when we put into the analysis and not much that drugs can help. But how aggressive that we are going to do with this type of, especially in the preserved ejection fraction, Professor?
Yeah. So as you know, HFrEF patients tend to be older. It is a depressing group of individuals to manage because every drug trial, and of course every drug trial is a very expensive investment from pharma companies, and in fact investigators such as you or I. It's quite an involved process to recruit patients, and of course it's been very disappointing. All the clinical trials for HFrEF with drugs certainly have been disappointing. I have to say that we use diuretics as our mainstay therapy. We do use spironolactone in those individuals as well. I think that TopCat was a study that was cheated. I think that there was a signal that was benefit. We can't say for certain because we have to go with the pre-specified endpoints and intention to treat, and the way the study was designed, it was a neutral study. But certainly I think there's signal enough for it to be worthwhile to give patients. And I think as long as serum biochemistry is monitored, spironolactone is a relatively safe drug. We haven't had, particularly if patients are on large amounts of loop diuretic, of course it's offsetting the potassium issue. So we do use spironolactone. We're not using sacubitril valsartan for HFrEF. If somebody had in the mid-range ejection fraction, it is a patient we would consider for sacubitril valsartan. In Scotland, we're allowed to currently give sacubitril valsartan for an ejection fraction of 40% or less. But of course, we all recognise that ejection fraction is not a precise thing. So on one day it might be 40%, the next day it might be 44, the next day it might be 36. What's the right thing for the patient? But certainly for HFrEF, it is a diuretic-based strategy. We have found cardiomems to be quite useful in selected individuals, but actually the most use I've found from cardiomems is in ensuring patients adhere to their therapy. And often what we see is in somebody with the pressures rising and rising, you phone them up and say, are you taking your furosemide? And they say, actually, no, I haven't been. So you say, take your furosemide, and the pressures come down again. So it's quite an expensive way of ensuring somebody takes their tablets. Is cardiomems used in Malaysia?
Say again?
Is cardiomems used in Malaysia?
Cardimem, I think I have to check with IJN. Our center still not yet use this type of pressure, but I think additional management, I think, is in the bigger institution like Institute Jantung Negara, which is National Heart of Malaysia. They sometimes use quite advanced technology. But so far in our center, in our university hospital, we haven't explored yet this kind of sensing. But I think it's surely benefit this cardiomen. But back to the historical drugs, Professor, before we go to the chat box there, usage of digoxin. So what I see in my clinical practice, digoxin, I love that, especially when you have a little bit of arrhythmia and the blood pressure tend to be low, especially in the reduced ejection fraction. So I tend to use digoxin. What is your experience and how do you manage these historical drugs in your center, Professor?
So, of course, the place that we usually use digoxin is in individuals with atrial fibrillation and heart failure to reduce ventricular rate in addition to a beta blocker. But, of course, as you know, the DIG trial was a sinus rhythm study. So it was a study where all individuals at baseline were in sinus rhythm, not AF. So we do use digoxin, but certainly not nearly as much as they do in the US. So roughly about 10% of individuals with heart failure and sinus rhythm would be on digoxin, no more than that. I think a sizable proportion of our AF patients, but obviously we give priority to beta blocker first and foremost, and add on digoxin if necessary. As you know, digoxin is also not great at controlling AF rate with exercise, so it usually has to be given with a beta blocker when somebody is euvolemic. There are instances in people with very advanced symptoms where digoxin makes people feel a bit better. I think the key, certainly from my reading of the literature, is to maintain a serum digoxin concentration on the lower end, certainly less than 1.2, because there is a suggestion that mortality goes up because it's got a very narrow therapeutic window, as we all recognise. And of course, many of the patients that we consider using it in are the elderly patients, and they're patients who could suffer the consequences of digoxin toxicity particularly. So we use it with caution and not commonly.
Okay. So, Professor, we go to the chat box there. One of the questions that was posted before, I think there are a lot of questions, but one that catch my eye there, when there are two drugs expensive, which is the drugs that new drugs, which is the HFrEF and also the SGLT2. So one of the audience here is asking, if you want to start, which one that you prefer, Professor? I think that one is quite difficult for me because my patient need to pay both of it, and we don't have a special subsidy from that group, that drug. So some of the patients really need to pay at the full price of the HFrEF and also the SGLT2. So one of the audience is asking, which one that you want to start first, Prof?
Okay, so good question, and I kind of anticipated this was going to come up. So what's key is the fact that sacubitril valsartan and dapagliflozin are different drugs working in different ways. And they're not competing drugs, they're complementary drugs. So obviously there were no patients on an SGLT2 inhibitor in Paradigm because it was before the SGLT2 inhibitors were routinely used. But 11% of patients in DAPA-HF were on sacubitril valsartan. So we do have some clinical trial experience. And certainly from that small proportion of individuals on sacubitril valsartan and DAPA-HF, there was no signal that they were benefiting any less or more than the general population. So these are not competing drugs, these are complementary drugs. And I'm speaking from the luxury of being in the UK where patients don't pay for their drugs. So if a drug is indicated and it's approved, the patient doesn't pay. So we are already using SGLT2 inhibitors in our patients. Virtually all so I polled my patients relatively recently, and these are HFrEF patients. 93% were on sacubitril valsartan, and we've already got just under 50% on dapagliflozin. Now, clearly, it's awaiting its heart failure license. We're allowed to give it in diabetics because, of course, it's got a diabetic license, but we are starting to use it in the non-diabetics as well. So I'm not forced to make the choice between one or the other. We give both. What I would point out, though, and this is important for the audience, is both have diuretic, natriuretic effects. Obviously, the SGLT2 inhibitors are osmotic diuretics, and again, it's another opportunity to reduce the patient's loop diuretic dose further, which patients are delighted about because they don't like their furosemide. If I had to choose, I would choose sacubitril valsartan because the evidence base is a bigger trial. It was done earlier, and every component that we've looked at in terms of reduction in pump failure death, reduction in sudden death is reduced. It's actually interesting. So this unpublished data, but data that John McMurray has shown me is, and there is a slide available, is dapagliflozin appears to reduce sudden death rather than pump failure death, which was a surprise to me. I thought as an osmotic type diuretic it would have an impact on pump failure death, whereas sacubitril/valsartan does it. Each type of heart failure seems to be reduced with it. So if I was forced with my arm twisted behind my back, I would say sacubitril/valsartan, but in reality we give both.
Okay. So some of the audience as well is asking regarding the dose of the ARNI itself. So some of it is because the dose, starting dose in the trial is 50, 100, and 200. So some of the practicing physician are using 25 milligram or half of the 50 milligram dose. So what do you think of that type of the management? I think this one I saw even in my own practice. Sometimes you want to compensate between the benefit and also the risk, which is some of them are really have the hovering blood pressure at around 100 systolic blood pressure. So you tend to use that half of the dose of the minimum. So what do you think of the dosing like that, Professor?
So I've never used half of the minimum dose before. So that's a surprise to me. I mean, normally what we do is we get rid of superfluous drugs as well. So it's quite common for a number of individuals to be on amlodipine, other types of diuretics such as thiazides, prostatic therapies, other things that can cause hypotension. But of course, a blood pressure of 100 millimeters of mercury doesn't bother me at all. And in fact, I remember my very first ward round in 1996 with John McMurray as a junior doctor. He was a terrifying individual, particularly in those days. And of course, blood pressure was mentioned on the ward round. And the main thing, and this is a Scottish phrase, but if a patient is pink and peeing, so if they're well perfused and passing urine, and they've got end organ perfusion, then blood pressure as a number doesn't really matter so much. So the vast majority of our patients are on either the middle dose, which you would call 100 milligrams twice daily, or indeed the top dose. And only a small proportion are on the lowest dose, 50 milligrams twice daily. You have the advantage you're allowed to call it 50 milligrams twice daily. We have to split it up into the individual components. We have to say 24/26 milligrams twice daily.